Hello, and welcome to today's HealthPayIntelligence.com presentation from RemitDATA, 5 tips to optimize narrow network performance. This is Kyle Murphy, Senior Director of Editorial at Xtelligent Media, here to kick off today's proceedings. RemitDATA delivers comprehensive comparative data and analytics solutions. Through the use of peer comparison tools, benchmarking, and application programming interfaces, health plans, providers, and other healthcare organizations are able to more rapidly identify and prioritize areas of concern, allowing them to better understand their business and enhance communications with business counterparts. We will begin with a presentation by our speakers and conclude with a question and answer segment. Audience members are free to submit questions at any time during the presentation using the question tool to the left of their screens. For all technical matters or difficulties, click the Help icon at the top right-hand corner of the screen. I would like now to hand things over to today's moderator, Matt Waltrip, Vice President, Payer Solutions at RemitDATA.
Thank you. And thank you all for joining us today for our brief webinar. Our topic for discussion today is optimizing narrow networks. As you all know, the increase in value-based contracting models is driving new innovations in the way healthcare is being delivered and paid for. The aim is for these contract models to foster greater collaboration by aligning incentives that will improve clinical outcomes and patient experience, as well as address the important goal of cost efficiency. During today's session, we'll take a few minutes to dive into a quick overview of market challenges, and we'll then move into a panel discussion exploring best practices and key considerations that align with the growing market demands for lower cost of care. Again, my name is Matt Waltrich. I'm the Vice President of Payer Solutions here at RemitDATA, and joining me today are Mike Isaac, RemitDATA's Senior Vice President of Payer Operations, and Dave Prue, Strategic Reimbursement and Contracting Consultant. And Dave brings extensive experience as an executive at a major health plan, so we look forward to his thoughts and insights here today as well. So let's start out by looking at some of the market challenges that health plans face in managing their provider networks with limited time and resources. Perhaps the biggest narrow network challenge for payers is driving meaningful cost differentiator through those networks. Payers typically need to see at least 10% lower premiums in order to sustain a limited network product, and this requires them to drive meaningfully lower cost of care. And it's very difficult for them to achieve this lower premium level purely through unit cost reductions alone. So payers must address inefficient utilization and be able to factor that in at the episode of care level as well. To elaborate on that a bit, as an example, a high volume facility may have a contracted rate that's well in line with the average facility cost in a given area. But if these fees aren't being analyzed holistically at the episode of care level, you could be missing a broader cost trend of inflated fees that are coming from episode-related services. That, for example, could be, say an anesthesiologist or maybe a post-acute care skilled nursing facility costs, which overall, again, for example, might be driving higher total costs for a knee replacement episode of care. Again, despite the fact that the facility cost itself may well be within average. In addition to this, as payers and provider contracting models evolve, it's becoming more common for provider risk-bearing entities like ACOs to seek ways in which they can better understand the major drivers that are contributing to cost variances within a common episode of care. So having the ability to see this at the episode of care level is a priority for efficiently managing the total cost of care. As you all know, successful narrow networks are designed with a unique mix of variables that factor in quality and outcomes measures, member choice, and of course cost. But the right balance of these variables is going to change based on the particular services or specialty that's in question. For example, quality and outcomes might be weighed very heavily for complex procedures, certainly things like cardiac surgery or, say, organ transplants, to take an extreme example. But more routine and higher volume procedures, for these types, these variables are still important, but patients are now increasingly more cost-sensitive shoppers, especially with the growth of high-deductible health plans. So procedures like knee replacements, upper GI endoscopies, sleep studies, colonoscopies, and other outpatient orthopedic procedures, for example, are becoming more and more cost-sensitive. And so in these instances, when the outcomes are more consistent, the mix of variables will need to be weighed more toward the total episode cost. And to accomplish that, We found that many health plans tend to focus on individual unit and service level cost as opposed to profiling providers based on their impact to the whole episode of care. For example, by getting insights into the impact that a surgeon's site of service decisions are having on an individual knee replacement cost, and having this kind of holistic episode view can drastically improve how you understand total cost of care and better refine your narrow network strategy. Today, most payers are building narrow network products around ACOs or provider-sponsored delivery systems that are under total cost of care contracts. And using narrow episode of care pricing and utilization analytics, you can get better insights into which providers you should engage for these narrow networks and which have the greatest cost impact. This will help you better recognize where to focus, see what the dollar impact will be, and really understand how to get the best results. So in our conversation today, we'll touch on a method for identifying these kinds of cost variances at the episode of care level and explore how you can leverage them for provider profiling, negotiations, and certainly reinforcing good practice patterns that are going to drive successful narrow networks. Okay, so let's move to our panel discussion and the question and answer portion of our webinar. And Mike, we'll start off with you. So carrying on the theme that I just outlined here, are there particular specialties or unique episodes of care that you think may be more actionable or impactful than others? And can you share your thoughts on how variable this may be from one health plan to another?
Sure, Matt. Great question. We consistently see the largest opportunity with common high-volume episodic procedures, which, of course, comprise a meaningful percentage of the medical spend in the United States. This ranges from imaging, diagnostic testing, outpatient surgery, and inpatient surgery. The list of procedures, in our experience, is generally the same across all payers, but the strategy to achieve savings in a given market is very specific to each payer, given their contracts and their volume with each provider. Matt?
Thanks, Mike. Dave, moving to you, how do payers need and use analytics to develop narrow networks?
Matt, they use analytics to address a variety of different factors. Typically when payers are developing narrow networks, the first thing that they need to do is identify the right mix of providers that meet their customer access needs, but also drive a materially lower premium price point. You mentioned in the intro that payers really need a premium differential of at least 10% to support a narrow network product. Quite often, payers are seeking to realize cost of care reductions in excess of 15% to meet the pricing goals that come with the narrow network products. And to achieve differentials to this degree, they need to identify more than just unit cost reductions. They need to identify providers that deliver care more efficiently and that will result in a reduction of avoidable utilization for the payer that can drive the significant level of cost of care savings that they're needing to accomplish to support these products. We found that episode of care analysis allows payers to identify the providers who deliver care most efficiently, which allows the payers to identify the most efficient providers for their networks. And additionally, this analysis provides payers with the analysis that they need to assist them with their savings estimates as they build their premium. Absent meaningful data that identifies where the savings potential is at the episode level, it's difficult for payers to get buy-in from their actuaries sometimes around projected savings. An episode of care analytics gives them a great set of tools to help with that process as well. Matt?
Absolutely. Thanks, Dave. Mike, can you elaborate on that as well? Maybe share some thoughts on how payers identify cost of care savings opportunities at an episode of care level, and how do they use this information to identify key providers they should be targeting for their narrow network strategy?
Sure, and just to tie into several of Dave's points, we find that it is important to have normalized episodic procedure cost analytics to truly compare providers across, these common high-volume procedures, but do so in a true apples-to-apples comparison, if you will. And what I mean by that is having the ability to compare the all-in costs for procedures, including all providers and all costs associated with the procedure, such as pre- and post-care for surgery, by way of example. But once complications, billing errors, additional procedures, etc., have been accounted for, to compare the total procedure cost in a fair and accurate manner that the payer can really stand behind. Once you've done this analytical approach consistently reveals a 400 to 500% price variance at the episodic procedure level, and most importantly, Matt, it identifies the cost drivers and the opportunities in each market when a payer's volume is incorporated. These analytics also identify surgeon site of service opportunities. A surgeon may be performing a procedure at multiple locations already. While that surgeon is usually paid the same, they are unaware of the episodic procedure cost variance among these facilities, and that variance is often significant. The goal is to help members access high-quality, high-value care within their network, and these episodic procedure cost analytics really help payers refine narrow networks well beyond the fee schedule and discount analysis in order to accomplish and realize the savings. Matt?
Thanks, Mike. Dave, what from your vantage point, what's the value of profiling providers based on episode of care costs?
Matt, I think profiles are important because they provide the payer with a means of ranking providers, and that's becoming increasingly important in today's marketplace. Good profiles give the payers the opportunity to create provider report cards that they can apply to the different geographies where the payers operate, and these report cards are useful for several different reasons. They provide the payer with support, database support of their own internal network decisions, their selection decisions. This information is useful within the health plan. It's also useful as the health plans communicate with their different customers to defend some of their network actions. And that's a very, very important step, and the episode of care ranking analysis supports that step quite well. Additionally, the report cards are quite useful to other contracted providers who may be at risk for total cost of care through their contract arrangements with the health plans. And these providers who have almost assumed the role of payer in some cases because they're actually at risk for the total cost of care, they're seeking insight around where they have opportunities to modify referral patterns. And report cards and provider profiling data are very, very useful to them for that purpose, so that they can modify the behavior of the patient population that they are now at risk for. Matt?
Thanks, Dave. Actually, another question for you, kind of carrying on that. What are your thoughts on how you could negotiate hospital and health system fee schedules based on total episode costs?
Yeah, great question. Well, for one, payers can negotiate episode fee schedules in the form of bundled payments that are becoming increasingly common with both CMS and also with commercial payers, as payers are looking for ways to drive cost savings for common procedures, and that space has been historically pretty tough to impact. And one of the big advantages of bundled payments in today's marketplace is that it provides a vehicle for realization of cost reductions for some high-cost line items that have been pretty tough to impact in the past, things like implantable devices. The structure of a bundled payment contract can help address that. And even though bundled payment is considered to be one of the the new and improved value-based reimbursement methods, it's still at the core a fee-for-service type method, and many providers are more willing to engage in a bundled payment contract, especially hospitals, than they might be willing to engage in a total cost of care contract. So that's one way. Payers can also use episode of care analysis to identify opportunities to modify fees to some hospital-based physicians. It's amazing how often this analysis can identify utilization patterns with hospital-based physicians that were not previously known, that gives the plan opportunity to make some fee schedule modifications in some cases. And the plans can also use this analytics to help with their hospital negotiations. As you're aware, some hospitals continually argue that they are due a higher rate, a higher fee-for-service rate, because they're more efficient than their competitor hospitals. And that's been an argument that some of the higher-cost hospitals have used for quite some time. Good episode of care analytics provides the payer with a way to measure whether these hospitals' claims are truly accurate and whether the hospitals are indeed more efficient. And this is information that payers can use in their contracts, potentially adjusting their contracts to allow for fee schedule modifications based on measured efficiency levels that the hospital has been able to demonstrate. So there are ways to use episode of care analytics to enhance even the most traditional forms of fee-for-service reimbursement. Matt?
Very good. Thanks, Dave. So, Mike, shifting to you, how can narrow networks strengthen provider relationships? And can you share some thoughts on engaging targeted providers?
Absolutely. You know, Matt, we find that many providers are just unaware of their impact on cost of care with a given payer, which is probably not a surprise, you know, because they've not really had access to that information. They may believe they have a very competitive contract in place, but episodic procedure cost analytics provide the payer factual data that's specific to that payer and their volume by procedure with that provider. In addition, these analytics provide insight into the component costs to help educate the provider on why their cost may be outside the norm. It could be the anesthesia cost, it could be the implant, it could be their clinical protocols are outside of the norm and driving up the episodic procedure cost. It could be high utilization of skilled nursing facilities and a host of other things. So, you know, it may in fact not be that provider's contract, but the provider may be unknowingly contributing to it. You know, we find that when payers are empowered with this level of provider-specific detail on that payer's member population with a provider, the conversation usually turns very collaborative. It often turns into a collaborative conversation instead of an adversarial conversation. You know, payers can work with providers to identify that win-win approach, which many of us believe is the most effective model for sustained savings. Matt?
Thanks, Mike. David, what do you think are some types of incentives that health plans are using to impact total procedure costs?
Well, Matt, in addition to the typical contractual approaches where payers are seeking to engage providers in new and different ways, leveraging analytics to the greatest degree possible, payers are also leveraging the power of consumerism to change behavior with procedures and associated procedure costs. And along that realm, payers are increasingly partnering with the larger employer community to steer selected high-volume, high-cost procedures to targeted facilities, an expansion of the old center of excellence approach. And in a lot of cases, payers are attaching these types of strategies with bundled payments that were derived through episode of care analytics. And these programs can vary. Typically, they take the form of providing patients with richer benefits for care received at a preferred center, and the benefit differentials can be quite significant in some cases. Another strategy that has been deployed and has actually generated some significant success is something that's referred to as reference-based pricing or reference-based benefits, where the payer actually sets the actual benefit for a procedure at a targeted rate that typically equates to a mean bundled rate for the targeted provider panel, and the patient is then provided with a lot of transparency around costs by provider, and then the patient benefit is actually set at the target rate. So the patient would receive full benefit if they went to a provider that had a target rate that was equal to or less than the plan's target. But if the patient selected a provider that had actual cost above that target, the patient would be responsible for the difference or percentage of the difference. So we've seen episode of care analysis not only impact contracting strategies, but also impact the ways that plans engage with their consumers, where we're seeing the analysis blended with tools for cost transparency to allow the power of consumerism to drive some behavior change. Matt?
Very good. Thanks, Dave. Okay. Well, that covers, I think, the main questions that we had here. So we'd like to take the opportunity to open this up to any questions that we have from the audience. So please feel free to enter those now. And it looks like we have one here. So I'm going to read this off, and Mike and Dave would open this up to you for your thoughts and feedback. So the question is, have you run into hospital resistance to giving up outpatient surgery in their system when the freestanding outpatient surgery center is much less costly?
You know, Matt, this is Mike. I'd be glad to make a few comments there. Dave, feel free to jump in anywhere along the way.
Sure.
You know, we certainly see across the country, kind of there's certain domains that providers would really like to protect, that they perceive as being meaningful revenue contributors. You know, they're obviously trying to serve patients and have to, have revenue to do that. But I would really kind of put that in the general category of, historically those conversations, it's kind of been an adversarial discussion, oftentimes, where they may want to protect their outpatient surgery center or a host of other kind of domains, depending on this specific provider. I think with episodic cost of care analysis focused on the procedure level, really having the analytics to have a collaborative discussion with the provider. Hey, here's what we're trying to accomplish. Here's how you're impacting that in a negative way. Here's opportunities for us to work together to make it a win-win. I think is really key, and I think core to our belief as to the ideal approach to narrow networks.
I agree, Mike. Just a couple points to add. I mean, and that's a great question, and the answer is yes. I mean, hospitals can be very resistant to giving up volumes, especially for services that have been profitable for them. I think where we have seen some change is in situations where we have provider groups that are taking risks for the total cost of care, where the provider groups now have a much greater incentive to drive savings opportunities, even if it means some referral changes. In some cases, the providers are willing to do that, even if it upsets some of their hospital partners. Not always, but in many cases. So I think that dynamic has changed things a bit. And I think the power of consumerism has modified that somewhat as well, especially as you see more and more members under high-deductible health plans, where the member has a much greater financial stake in the game than they used to be, and members are willing to push that type of a conversation with their doctor, and that tends to help with some of those changes in referral patterns that could otherwise be difficult.
Excellent. Thanks, guys. Looks like we have another question here. Can you elaborate on best practices for engaging targeted providers?
This is Mike again, and I'll be glad to add a few. Dave, again, please help me out here along the way. A few thoughts on that, Matt. One, I think having the analytics to really refine your focus on which providers in a given market represent the biggest opportunity. Really using a scalpel versus a sledgehammer, if you will, to hone in on which providers represent, the most value, and spending your time and energy on those providers. With that said, we see different approaches working for different payers. Each market is different. Each payer's business is different. As Dave alluded to, incentives, and those can take many different forms. If it's shared risk, that obviously is a built-in incentive, as Dave alluded to as well. But also incentives for providers helping meet certain targets, certain cost of care targets. Oftentimes a meaningful impact is realized just simply through provider education, and there's certainly going to be those that aren't going to want to go easily. And in that case, there's other tools and methods, that are kind of very specific to a payer's market and their relationship with their providers. Dave, anything you would add there?
Yeah, no, that's great comments, Mike. The only thing I would add is that this really is just piggybacks onto your first comment. I think providing insights to providers that are actionable, or that are presented in a way that are actionable for the payer and for the provider. I think historically, much of the episode of care analytics that has been presented has been a little bit black box. And most people are aware of the fact that hospitals in most cases are more expensive than freestanding providers, and sharing that type of insight doesn't do a whole lot. But when you add to that information around the referral patterns that are driving those differentials, or some of the specific billing patterns that are driving those differentials, along with some ideas on things that can be done to change some of those behaviors, the information just becomes a lot more powerful. And I think that type of insight, I think, is a real best practice in this space.
Very good. Thanks, guys. It looks like those are the questions that we have. So unless there are any others, I think we'll wrap it up on that note. So we certainly hope you all found this session beneficial, and if there are any questions or other areas here that you have interest in that we did not cover, please certainly feel free to contact us. My email address is here as well, but you can also reach us at marketing@RemitDATA.com, or if you'd like to have a more thorough discussion regarding episode of care, we would certainly be happy to schedule any follow-up. So we'll be emailing an FAQ and the recorded webinar for you to have as well, with a copy of the presentation. Again, thank you for joining us, and we'll look forward to having you join us again for the next webinar, touching on applications of episodes of care.
With that, we conclude today's presentation, and with it a special thanks to our speakers and RemitDATA. And for the latest healthcare news and insight, visit healthcareintelligence.com. Thank you, and have a great day.